Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our quick sessions in which we summarize together one of the top articles. And today we have a recent one, July 2023, the recent trends in molecular testing in ovarian cancers. You may have encountered while you are reading the treatment for ovarian cancer something like we are going to use the PRP inhibitors, or we are going to use this agent for a specific kind for ovarian cancers. And you may wonder, what are those? Those are going to be our aim today. We are going to understand what is molecular testing and how it would help in the management of ovarian cancer. You all know that surgical cytoreduction and platinum-based chemotherapy are the mainstay for ovarian cancer treatment. However, unfortunately, 70% of patients with advanced stage disease will relapse after responding to the first-line chemotherapy. This is very intimidating. This is very depressing. That's why we were searching years over years for something that would help us to improve the survival for those patients and to help us more to know about the nature of the cancer and how the genetics can help us through this. So we have agents like PRP inhibitors, which I call Barbie, or bevacizumab, for example, or other agents that really showed improvement in progression for free survival rate. So let's see how this works, how we gonna get the idea of those inhibitors. What are those inhibitors in general? Okay, before we go there, I want to remind you that the fact that P53 mutations were almost 96% found in high-grade serous carcinomas. This is something we need to know how to stop this or how to use this in our benefit. We know that BRCA1 and BRCA2 also took a role in ovarian cancers, but they are not as common as the P53. However, they showed superior sensitivity to platinum-based chemotherapy. And that's why when you have a patient with P53 ovarian cancer, usually we say she's having poor prognosis. Why? Because we know that she's not going to have maximum benefit from the platinum-based chemotherapy. And this is why we were thinking of another thing. Like, for example, we need to know what is DNA damage response. DNA damage response is an umbrella term for several DNA repair mechanisms. Those mechanisms are working perfectly in our body, like mismatch repair, like base excision repair, like homologous recombination repair. All those repair mechanisms are working perfectly in our body every second. When we have a deficiency on those repair mechanisms, we are going to have some diseases. And for the cancer cells, when they have those repair mechanisms active, they are going to be active. If we can, by any means, stop those repair mechanisms for the cancer cells, then we are going to compete those cancer cells. The mismatch repair, for example, is very well known for Lynch syndrome, right? And those are in particular the repair mechanisms that we search for. And if we see some types of them, we know that this woman is having Lynch syndrome. Okay, let's see how we can stop this, how we can incorporate something within those repair mechanisms to stop the replication of cancer cells. So we need to know about the HRD, or homologous recombination deficiency. This is the HRD, or the HRR. Sorry, not D means deficiency. The HRR is the one responsible for the repair of double-strand break in DNA. The HRR and the NHEG, both together. Okay, so if I'm having a break in the double strand of DNA, then the HRR is going to interfere during the G2 or S phases and utilize the sister chromatide to make a template and repair the damage, right? Okay. The good news is we have discovered that the HRD or the deficiency is encountered in almost half of the cases of the Cancer Genome Atlas. So this is something, right? So this can happen by either the loss of function or by silencing the epigenetic events that encode the HRR pathway proteins. Anyway, if the cell is having HRD deficiency in the HRR, it's going to rely on the less efficient NHEG pathway. And when it does so, sometimes this could lead to inevitable genomic instability. When we get all this, we can make use of these mechanisms in our side, right? So again, they are not working alone. They need enzymes. So we have something called PARP or poly-ADP ribose polymerase. Those enzymes are crucial in single-strand DNA repair pathway. So if I'm having a single DNA break, the PARP is going to come in, try to fix it, repair it, and the cell is going to survive. Okay? And if it does now, and I'm okay now, I have converted the break into double strand break. Okay, I'm having a problem if I'm having HRD, if I'm deficient in the HRD. So if I'm having HRR working efficiently, I'm going to have a survival. If I'm having HRD deficiency, this cell is going to die. And that's what we want for cancer cells. We want something to interfere with the PARP, and we want to have the HRD deficiency. Unfortunately, fortunately, we have HRD deficiency in most of the cancers already. They are there, they are present. So what I'm going to do is just interfere with the PARP. And this is what we call BARB or PARP inhibition. If we inhibit those enzymes, we are going to have accumulation of DNA damage and cell death. Those are our way to make a cancer cell die. Can we do it? Yes, we can. And we have managed to do so. When we have the PARP inhibitors as tablets and give it to the patient, it's going to target the cells, the cancer cells, and it's going to inhibit the repair of the single brand break in DNA. Okay, this is how the normal BARB function, as you can see, and those are the proposed BARB mechanism of action. There is something called PARP trapping. We are going to interfere with the trapping when the PARP endorses itself in the single strand DNA where the break is and try to fix it. So we need something to interfere with this trapping. Or we can do upregulation of the NHEG because, as we said before, this one is not really good in its work and it's not really efficient, and it can lead to DNA instability in most of the cases. So if I do upregulation in this system, I'm going to result in DNA damage. Or maybe I can do increase in the replication speed of the DNA or the wrong DNA, the one with the lethal components. And again, this is going to lead to DNA damage and cell death. Those are the proposed mechanisms. Okay, without further details about what is replication fork or PRP trapping, if you want to read about it, it will be amazing. Okay, and I tried my best to simplify it here. But I want you to get the main idea. The main idea is that we can use the PARP or the PRP inhibitors as oral preparations to maintain the therapy after chemotherapy. Or we can use it as a first-line maintenance therapy also. So it can be used with concurrent chemotherapy, and we can use it after response to chemotherapy. The currently approved one now is the olaparib, niraparib, and rocaparib. All those three are approved by the FDA, and they are present in forms of tablets or capsules. The olaparib can be used as maintenance therapy up to 2 years, either alone or in combination with the bevacizumab, as I told you in the very, very beginning. Niraparib should be given like up to 3 years. Okay. So here we have some studies approved by the NICE guideline about each medication, the commonest adverse effect, the significant clinical trials that used these agents, and what we should know about them. We know for sure now that the olaparib is approved by the NICE guideline, and this is what we care about in our practice and in our exam. They are approved for being a maintenance therapy for advanced ovarian carcinoma, stage 3 and 4, high-grade epithelial ovarian carcinoma, with BRCA1 and 2 mutation after response to the first-line platinum-based chemotherapy. We know, again, that the nausea and vomiting mainly are the main common side effects. However, in the case of niraparib, you're going to find that they are going to have thrombocytopenia in up to 61.3%. Again, they are fully approved as maintenance for relapsed platinum-sensitive high-grade serous epithelial ovarian cancer. They are recommended at least 2 courses after at least 2 courses of platinum-based chemotherapy, regardless of the BRCA status. The rocaparib here, again, the nausea is the most common side effect. And again, they are approved within the CDF. So CDF is a Cancer Drug Fund, not the NICE guideline. The NICE guideline approved fully the niraparib and the olaparib, as you can see. And for some types, like the relapsed platinum-sensitive high-grade ovarian cancer, after the relapse or, after response to the first-line platinum-based chemotherapy, we can use the ROCA1. Do we do HRD testing in UK or not? If you are going to do a guided omental biopsy, you need to have at least 5 cores for sufficient sampling for HRD testing. Because as we said before, the idea is I need to make sure that this type of cancer is having HRD. They are having a deficiency in HRR. So if I introduce the PARP, I'm going to block every mechanism for DNA repair for the cancer cells. So here, we have HRD testing in the UK. The Marriott, my choice is the newly diagnosed 3 and 4 stage non-mucinous epithelium histology. That was the first one eligible for this treatment. And of course, This is for now. We don't know about the future. So this is why the authors are telling you that this could be amended in the future. The genomic assessment within the NHS is provided through the network of the 7 genomic laboratory hubs. If you want to search for them, it will be great. If you want to know the sites of those laboratory hubs. According to the National Genomic Test Directory, the BRCA1 and 2 testing is provided through GLH for patients for any non-mucinous high-grade epithelial ovarian cancer, regardless of the stage. Those are exam questions. If we know that all those patients can be offered BRCA1 and BRCA2 testing, and we can offer them HRD testing if they are non-mucinous high-grade epithelial ovarian cancer. If they were found to be HRD positive, then we can give them the PARB as maintenance therapy after the first chemotherapy. What are the drawbacks? Of course, there is a trick here. Can the PARB be better, or placebo is better? Let's see. Of course, there is increased risk for severe adverse effects. Yes, we have seen together that nausea, vomiting, thrombocytopenia, and other side effects can happen to those patients. And of course, this will need an informed consent from the patient, and it will be her choice. However, when we do the quality adjusted questionnaire, what we call the free survival period, or the adjusted time without symptoms of treatment toxicity, when we do those, we will find that the benefit of survival against the potential effect and the possible impact on quality of life, and then we can decide if we are going to go through this treatment or not. Another concern with the PARB is the development of secondary malignancies, like high risk for myelodysplastic syndrome or acute myeloid leukemia. Yes, we have been able to target the cancer cells, but don't forget that this is a systemic therapy, so it's going to affect other cells also. Sometimes we have a PARB resistance. We are not so sure if all patients are going to 100% agree with PARB and do not have a complete complete removal of the cancer cells with PARB. Sometimes there is a resistance also where we find a relapse. The idea of oligometastatic recurrence, this is our problem whatsoever with any cancer. The idea that there is oligometastatic recurrence or micro lymph node invasions or low malignancy index or volume. This is one of the reasons why we have a relapse in cancer, because we don't have an efficient therapy to target those micrometastases in every kind of cancer. Specifically, the ovarian cancer, which is the most challenging one, we have a solitary site relapse. So sometimes we have found that there is an oligometastatic recurrence while follow up on first or second line PARB maintenance therapy. So those were the drawbacks. We still have many studies going on PARB and their effect as maintenance therapy. We still want to hear more about the side effects and how to control them. We are hopefully praying for reducing the development of secondary malignancies with PARB. So let's see, let's hope for the best. This is the end of my discussion with you today. Hopefully I have made it easy for you. If you have any questions, please leave it in the comment section, or you can contact me in person, of course, in the Telegram. Thank you so much for being here, and see you next time, inshallah.